Welcome to the Shockwave Therapy Podcast. My name is James Woolidge, osteopath and clinical director at the Abbeyfields Clinic in Suffolk. We will be trying to demystify the concept of shockwave treatment whilst bringing together experts in their field to discuss the latest research. If you are deciding on whether to add this modality into your clinic or just improve the way you deliver it, then we hope this is the podcast for you. Today we'll be talking to Benoy Mathew, an extended scope physiotherapist specialising in lower extremity injuries. He splits his time between NHS practice at the Croydon University Hospital and in private practice at Mayfair. He teaches across the globe in tendinopathies in particular, with particular reference to groin pathologies and hip pathologies. He's been teaching over 2,000 participants on CPD courses over the last 8 years, using Shockwave for the last 7 years, so he's very experienced in that area. Today we're hoping he can shed some light upon greater trochanteric pain syndrome in particular, amongst other tendinopathies around the hip. So welcome, Ben. Thanks for joining us this evening. We're going to try and focus as much as possible today, talking about your particular interest, which is on hip pathology, with particular reference for Shockwave and greater trochanteric pain syndrome. So for those listeners out there that haven't heard of you, can you just give us a bit of a roundup of your career so far and how you got into Shockwave and tendon disorders?
Thanks, James, for inviting me on the Shockwave podcast. And I've been working as a therapist for the last 20 years. Currently, it's a bit of a mixture of various roles. So I work part-time in the NHS as an Advanced Practice Physio, where predominantly I deal with lower limb clinics, working with consultants. I also do private work, which is exclusively hips and runners. So like yesterday on my hips, on my Mayfair day, I had about 12 hip patients, mixture of intra-articular, extra-articular patients. I've been using Shockwave for the last 7 years and been teaching for the last 3 years. So for lower limb, especially with my hips and knees, it's sort of a very valuable adjunct, which pretty much I use it every week. When I started, like with most therapists do, I was just focusing on the Achilles and plantar fasciitis, but over the years I've sort of moved into other areas which I found really useful. Okay, all right.
And so your most of your career is split now between NHS at, what's the hospital you work at, Ben?
Yeah, currently I work at Croydon University Hospital, and then I have work in the Mayfair Hotel, which is within the hotel. So we've got a gym. And also, along with my business colleague Len, so we got a few therapists as well. So it's exclusively like a lower limb specialist clinic. So I've only been treating lower limb for the last 4 to 5 years. So predominantly hips. That sort of is what I'm focusing on.
Okay, and what kind of populations are we talking, Ben? You treat lots of sports people? Do you treat sedentary people, or is it a general mix because you're in NHS and private?
Yeah. So NHS, I don't really. It's more like a triage role. It's more like an ESP role. With my clinical role, I would say it's predominantly an active recreational population. I've stopped working with semi-professional football and other sports. So it's predominantly like you're a typical city goer, works 40, 50 hours, but still thinks he's an athlete, puts 15 to 20 hours, you're overusing injuries. So I don't really see much of, I hardly see any chronic pain cases. And because I've not treated spine for a long time, I'm not involved in that area. So predominantly it's like your runners, your semi-professional, bit of footballers, hockey and all that. A mixture of recreational athletic population. So anywhere from 16 to 45, that sort of is the typical age group I see.
Okay, fine. Just if you can, with your experience in hip pathology, because this will be listened to, as I know, by a mixture of professionals, podiatrists, osteopaths, chiropractors and so forth that are interested in Shockwave. Can you just give us a quick roundup of what GTPS is?
Yeah, so I think whenever you heard the word syndrome, you can be sure that we don't understand it well, like, subacromial pain syndrome. So it's a nice way of saying, like, we really don't know what's happening. But GTPS, I think it's a better word rather than saying trochanteric bursitis or gluteal tendinopathy. Because just to give an example, like if you scan 100 people with GTPS, about 60 will have pathology on scan. 40 you will have a normal scan but still have pain. So there's a sort of a lack of link between imaging and pathology. So we can see it's a spectrum of, we think it's mainly a tendon-related issue, just like the shoulder. So main the two tendons is glute med and med and glute minimus. I think the bursa involvement is only around 5 to 10%, and we think bursa is a victim to tendon issue. So we don't really believe that it's the primary driver. I still get referrals from my GP. I still get referral from GP saying trochanteric bursitis, can you inject? Or on that, we think it's more like a coexisting pathology, like for example, like in the shoulder or the insertional Achilles retrocalcaneal bursa. So I don't really look at the bursa in isolation. So I think the main factor is the tendon, and with any lower limb tendinopathy, it sort of follows the same protocol, and it has a slightly higher predisposition to women. Sort of the ratio is 4:1, and the stats are quite scary. It's like at least 20 to 25% of women after the age of 40 will have some form of GTPS at least once in their life. So it's extremely common condition, and I can say this because I work in both the sites. It's very poorly managed in many areas, especially within the NHS and many places where people rush into multiple injections, which lead to poor outcomes in the long term. So,
sure.
Although it's common, it doesn't mean it's well managed.
And do you think, I mean, certainly for me, as training as an osteopath, I think that if we went back 15, 20 years ago, if you had lateral hip pain, it was likely due to some, your spine's out or your pelvis is out, and it's probably referred pain from your spine going to the side of the hip. So actually, it's, being involved in shockwave and tendon disorders, as I have for the last 5 years, it's been a real eye-opener as to how common it is as a condition. I just want to go back to what you said about that it's slightly women more than men. Is your take on that, because I know that some of the things underpinning tendinopathies are metabolic, hormonal, as well as mechanical. Do you see there being those two things in place for GTPS, or do you see it more as a mechanical issue about pelvic girth and Q angles and so forth?
I'm more into the hormonal camp, because I think we know that predominantly I see the patients in a peri or postmenopausal women, and we know that there's a drop in estrogen, which is extremely important for tendon metabolism. It is very important for collagen turnover. So I think the key driver, in my opinion, and also looking at the literature, is metabolic and also change in the sex hormones. So that sort of tips in, and also BMI is a big factor. So it's not a surprise. If you look at the stats, an average person with GTPS usually has a large BMI.
Sure.
Obviously, the mechanical factors is important, like weak hip abductors, large Q angle, and women have that slight mechanical disadvantage because the wide pelvis puts the abductors into more strain. And if you want to go really into detail, especially a hip person, there are a few variations in the hip, such as called coxa vara, where you have an angle of the hip which can put more strain. So I think those factors are important. But I think what tips people is the hormonal factors, combination of weight gain and lack of activity. Things which happen in most men and women when you reach a particular age where, you gain a bit more weight, you lose a bit of muscle tone, and you have a drop in your sex hormones. That has a bigger impact on your tendons than mechanical factors. I think that's it's a combination, obviously, mechanical and hormonal, but the hormonal factors are more important in the 40 plus. On the other side, I do get, few patients, for example, I do get like a 24-year-old female runner with lateral hip pain. There, the mechanical factors are more important because, for example, she started doing uphill running. She has a crossover gait, or there is some impairments and things like that. So the age group makes a big effect on whether you think it's mechanical or hormonal. Yeah,
that's really well put. Thanks. So the next question I was going to ask was at what point, if you're presented with a patient that has lateral hip pain syndrome or greater trochanteric pain syndrome, at what point do you start making a decision about when to use shockwave as we both agree on, as an adjunct to what you're about to do with that patient? Do you jump straight in with it? Do you try other things first? When do you use it in the timeline of your treatment strategy?
I think if you look at the literature, it's very clear that it's not the first line of treatment. So most protocols will say that you need to try at least 12 weeks of conservative management, which should include a graded loading protocol before we think into adjuncts like, shockwave, PRP, patches, or whatever, is available. So it's a bit different for me because I never ever seem to see people in their acute stage most more patients I see are second opinion or third opinion. So an average person who comes to me, their symptoms have been at least 6 months to 1 year. They've done physio or osteo or somewhere else. They have not improved. So in that group, I don't really drag them for another 3 months for rehab before Shockwave. So in practice, what I do is a multimodal approach. So they come to me, for example, somebody comes to me, is 8 months old GTPS. They've done 2 months of physio or osteo somewhere. I'm going to start them multimodally. So obviously they'll get the rehab. They'll have the advice on load management and all that stuff which you do normally with tendon. But I will also start concurrently with Shockwave, because what I don't want to do is drag them for 3 months and then say, let's start Shockwave again.
Sure.
What I've changed recently is I've been using you get questionnaire, for example, like Visa G, which is a specific outcome tool for hip. So it starts from 0 to 10, 0 to 100. So you could do it like an outcome tool when they come in, and then assess that in 6 weeks. So this is what I normally say: in 6 weeks, if you've not had any improvement, then we might start Shockwave, which I think is reasonable. In private practice, most patients will not wait for 3 months. If they're not improving in 4 to 6 weeks, they will go somewhere else.
Yes.
So I think most people are happy to try for a month or 6 weeks. So basically, it kickstarts your healing by a little bit of pro-inflammation, and then basically it facilitates your engagement in rehabilitation. So it's an effective painkiller. It stimulates your healing mechanism, but it doesn't improve your tendon capacity and your function on its own. So I always make it clear that it's the limitation of Shockwave. It's a fantastic tool, but the only thing which can improve tendon capacity is graded loading. You can't just use a passive technique and expect your tendon to change its capacity. So it's really important that we de-threaten Shockwave and say it's. So sometimes I play it down and say, like, it's not going to fix it on its own. But it's a great tool. We know that it works. It works by desensitization, and also reduces the sensitivity. And once the pain is reduced, then I can load you better, and then your function will improve. So it's part of the pathway. I've never ever given, in my last 7 years, I've never ever given Shockwave as a standalone treatment, which in my opinion is not good practice. It's always multimodal.
Yeah, well said. I think that was brilliantly put about the concept of capacity, which I think when people are dealing with tendons, they don't use that word enough, because I think actually if we're going to use words like overload, I think actually that's accurate, but it can be quite negative. But using a concept of increasing capacity is something that I always have thought it's got rather more of a positive influence on the patient, to say, well, I can improve your capacity, so therefore load will never breach capacity. So that's really well put. So we're talking about, again, this adjunctive issue. What in terms of how much data there is on plantar fasciitis and Achilles?
Yes.
What is the data that exists now in terms of greater trochanteric pain syndrome? Is it catching up on those two key areas of plantar fasciitis and Achilles, do you think?
Yeah. So for example, the evidence is overloaded in plantar fasciitis. In my opinion, we don't need more trials. I think there's at least 100 to 150 trials there. So it's well proven, multi-center trials, and you can say similar to Achilles. I think from a GTPS point of view, I think the first trial was in 2009, I think, with Jan Rompe, which showed like comparing injection and then rehab and GTPS, which showed good short-term and long-term up to, I think it's 15 months or 24 months. So, which is pretty good for a clinical population, isn't it? Like,
yes.
Anything more than 1 year, I'm quite pleased. From the last count, from my reading, I think there's been 6 trials, four on radial and 2 on focus. The good news is none of them showed any adverse effects. All of them showed a good outcome both in midterm and long term. And let's put that in perspective. So I get this constantly, so bombarded by people when people say, oh, there's not much evidence. If you look at the evidence for exercise, for example, in GTPS, the only RCT which has been published only came out last year in the BJSM, the famous LEAP trial.
Yes.
So if you can argue there's more evidence for Shockwave than exercise purely from a scientific point of view, But I'm not saying like it's the first line of treatment. So, people who dispute Shockwave, I've not actually read up on the evidence, especially in the last 5 years. So 6 trials is not, it's not huge, but, they're well-controlled trials, some are RCTs, There's no adverse effects, and all the patients which have been used in that RCTs in the 6 trials are patients who have failed conservative treatment, the first line. So nobody's saying that we should stick in Shockwave on the first visit. But if they're not improved, then it's a logical thing to do.
Yes, I think that's quite right. And I remember looking at that LEAP trial. I think I'm right in saying that it was something like it was 1 or 2 sessions per week for about 18 weeks.
Yes, and a total 14 sessions. And so this is the thing, people, especially, you work in the, private sector, and people jump on the exercise bandwagon and say, exercise is better. Yes, exercise is better. But the original trial used 14 sessions, 1/4.
Yes.
And how many insurance companies or NHS places offer 14 sessions?
Yes.
It doesn't happen, So if you want to have good rehab, you need to put in the work. But sadly, because of financial reasons or because of certain limitations, people don't get that 14 session. I'm just going off the tangent, I think which is relevant here is, I was recently teaching in Denmark, and I was talking to this guy, they were getting amazing return to play following ACLs. So I was asking, how many sessions do you see them after ACL? And he said an average of 40 to 60 sessions. That's what they do. 40 to 60 in 1 year, And if you're giving 40 to 60 in 1 year, obviously it's amazing, isn't it?
Yes.
So if you want to think exercise is good at best, please do give them enough sessions and don't expect, because we know the exercise takes time. You're not going to get an improvement in 2 sessions or 3 sessions.
Yeah, sure.
Yeah.
Okay, so if we can just change tack a little bit. So I teach alongside with you, and I certainly have found that people do like to sort of get into the absolute detail. They want to be given a sort of formulaic, is it 3 sessions at what bar, at what frequency, and so forth. So what, after 7 years of you using it, do you have any strategies that you use to decide on, particularly with session number? So I know that some people are out there saying that they just block book 6 sessions for everything. I personally don't. But how do you construct your treatment sessions?
I think you must have gone through the same journey. I've tried the whole combination. So when I first started, when I first was exposed to Shockwave, which was in Oxley's in Greenwich, we had a policy. We only gave 3 sessions. So that's what I was told. You just do what you're told by your boss. So I just stuck to that. What I found was it seems to work really well about 60% of patients. Like, for example, the Achilles and the plantar fasciitis. What I found was it doesn't seem to really make people take off the edge in especially hip pathologies and patellar tendon. So it seems like those areas needed a bit more. So what I did was what I've changed in the last 1 or 2 years is there are 2 factors I feel are really important in the number of sessions. The first fact is chronicity. So you got 2 patients in a clinic. One had GTPS for 5 months, and another had GTPS for 4 years. Obviously, they're going to be different, isn't it? They're not both going to respond on that. What I use is, if your pathology has been more than 1 year, I say to my patient, it's more likely that you'll end up needing at least 4 to 5 sessions. That 3 might not be enough. So that's sort of, I find, anecdotally, the more chronic they are, you need that more stimulus to get in there to create that sort of, healing response and the inflammatory response. That's one element. The second element I find is the hip tendons, because you get a lot of dissipation of the energy by the adiposity and the depth of the region. So I find, like with the hip conditions I give predominantly is the 3 hips I give is lateral hip. I'm a big fan of using on my adductors. I use that a lot with my male patients with adductors. And the third condition I use is the proximal hamstring, which we use in middle-aged runners and, very common in the runners. The one I've sort of now gone into is, we know that there's a minimum of 3. That's the minimum to get that effect. You sort of reach the ceiling effect after 5 or 6. I don't really see much point after that. So what I tend to do in my clinic is the hip tendons, those 3 tendons. I've sort of, I found this has worked for me the last 2 years. I offer them a package of 5 sessions. That's what I do.
Right.
It's always 5 for those 3 areas. Could be because it's deeper, it's a bit more, you get a lot of wastage with the radial with that. It's not superficial like the Achilles or the plantar fasciitis. So I find that 3 gets them a bit better, but 5 seems to make them, really completes the journey really well.
Sorry, I just missed the first one of the tendons that you mentioned around the hip. We've got the GTPS and we got high hamstring. What was the other condition?
The adductors.
Oh, do you? Right. Okay.
Yeah, adductors. It's one of my favorites. And if you look this is the thing. If you look at the evidence, there is only one trial, as far as I know, which. So I think I was at one of the sports. I think it was in Holland or France, one of the places where I was dealing with one of a semi-professional club's physios, and he said to me they're having good success with adductors and osteitis pubis. So I thought, why not? Because it's the same tendon. It's like any weight-bearing tendon.
And you're using radial for that now.
Yes, yeah.
For all of those.
All of those for the radial. What I tend to use as well is around the bone area. I tend to use the ceramic, the soft focus.
Sure.
Because it's very sore if you go directly with your normal head. So I tend to use the soft focus around it. And I picked up from other clinicians. I tend to always do a little bit of myofascial work with my D20. Sort of work on. So for me, it's a combination of three things: work on the muscles, work on the bone interface, and then the tendon. It's a one unit. I'm just not treating the tendon in isolation. It's a combination treatment.
Fine. And because on this podcast I say at the start that we're not trying to be denominational and religious about what machines. So for people listening, that you mentioned ceramic, that's a Storz specific head that we use that has just basically dissipating energy much better. And the D20 is a sort of massage type device that comes with it, isn't it? I'm not sure whether other machines, or what I should say at this point, there are other machines on the market, but that's pertinent to the machine that you have. So have you found anecdotally any particular group or any particular individuals that respond particularly well to Shockwave that you would be like, that's the condition I want to see, that's the age, that's the sex, and so on and so forth?
So I think you learn more from failures than from success, in my opinion. So I can tell you the ones which I find don't respond, but then I can tell you which respond well. The ones I find really difficult with Shockwave are the patients who had multiple steroid injections.
Right.
Somebody comes to me, lateral hip, and they said they had 4 injections in the last 2 years. I'm going to be very honest with them and say, we know that steroids causes cell death, reduces, it weakens your tendons, cell degenerate. We know all the negative effects on steroids on tendons, especially multiple injections.
Yes.
We're talking about people like my nightmare patient is like a 10 years ago patient who had 6 injections. That's it's not going to be as effective. So those patients, I'll tell them, like, obviously I'm going to try Shockwave, but I'm going to only give you 50-50, or not even 40% or something like that. So I'm very honest up from saying, like, it might not be as successful because, once you have been messed around with multiple steroids, it doesn't seem, that's my, experience. They don't seem to do well. That's one group. The second group, which comes from a bit of literature from your, plantar fasciitis, is people with uncontrolled diabetic, where they have the sugars is all over the place. Because we know that's very important for healing. So an uncontrolled diabetic patient or, very large BMI, it's all, they don't, they're very, they get flare-ups, they don't respond. And the last group I find who don't respond really well is people with an underlying rheumatological condition, like psoriasis, rheumatic arthritis or ankylosing spondylitis. They don't seem to respond the same way with like somebody with a mechanical component, So they seem to take longer and they don't tolerate heavy doses. So those 3 groups, I do try on those 3 groups, but they're not my most successful of groups.
Yeah, sure.
Talking about people, Now talking about people who do well are, again, there are 2-3 types of groups I find GTPS. First one is patients whose symptoms are less than 1 year. Because, if you have symptoms for 4 years, you're going to get a lot of other associated factors, central sensitization, associated kinetic deficits, pain response. Everything gets altered, isn't it? The whole nervous system becomes a bit mashed up when you have pain for 4 years. So I find the more chronic you are, you don't do so well as somebody whose symptoms is less than 1 year. That's that one group. The second group I find is, who are generally having a good function before. For somebody who comes limping in, they're having severe night pain. I tend to try to discourage them from Shockwave till I build their capacity first. Sometimes I feel you need to be strong enough to take the Shockwave first.
Mm-hmm.
If you come very sore, very weak, very painful, they can't take the dosage, and if you don't give them dosage, nothing works, isn't it?
Yeah,
so,
sure.
I tend to avoid shockwave in very acute patients and who are really deconditioned. So sometimes I'll say, I think you need 1 month of rehab just for the shockwave. You need a bit of prehab for the
Yes.
shockwave. So
Okay.
you need a little bit of strengthening. So for example, I might do like a GTPS. I might expect them to do at least like a 10 bridges and at least 20 to 30 seconds single leg stand. Simple test I use.
Sure.
If they can't do that, then I would say let's get you strong a little bit first, and then we can because it's a painful stimulus, and I don't want to give it till I think you're ready. So that's what I've changed. Before I used to rush into that. Now I sort of build them up to that. It's like a prehab before surgery.
Yeah.
We got evidence from ACL and other hip surgeries that 4 to 6 weeks of prehab improves your outcome.
Yeah.
And I use the same principle with my shockwave as well. So 4 to 6 weeks of prehab.
And do you use that across all the tendinopathies, or is that particularly for the hip?
Yeah. All the tendons, especially weight-bearing tendons. I would say 90% of my treatment is lower limb, so I can't really comment on upper limb. But
Sure.
for my patellar tendon, lateral hip, Achilles, I sort of build them to a minimum capacity where I feel they can take that dosage, because it's a pure physics thing. For example, if you come with a lot of pain and you can only take 2.2, for example,
Yeah.
and
That's 2.2 bar, isn't it? Yeah.
Bar, 2.2 bar. And if I build them up and you can take 3 bars, so I put more energy in you, isn't it?
Yeah.
And you're going to get better response because the cellular response will be higher. So there's a bit of selfishness in me there to get them ready so that they can take maximum dosage, which we know is the biggest predictor of improvement, isn't it? So if you're too sore, you can't handle it. So you need to be strong enough. I think that's one of the mistakes I see is it's not about shockwave is not the right. It's all about the right timing of shockwave. You should give them when you think it's the right time where they can take it at that appropriate dosage.
Yeah, that's nicely put. That's food for thought. I hadn't thought about that myself actually, because I like you said at the start. I think it's got particularly I found with GTPS, it's got a really nice pain relieving effect, and a lot of people with that condition are sleep affected because of the pain. And I think that actually, from my point of view, if one of the things that you can change is their pain and sleep better, from a metabolic point of view and a hormonal point of view, that gets them going really well.
Recovery.
Yeah.
So the things, simple things, I could share here is, you don't have to make it complex with patients. Is somebody is having, severe night pain, point blankly, I won't give shockwave because we know without sleep nothing happens. You recover, nothing in your MSK. So somebody is waking up 3 times at night because of severe pain. I say to them, shockwave is not going to fix that. So let's get the sleep sorted first. Get that sorted. Somebody is limping, they can't even walk 5 minutes. Get them a little bit, at least walk them 10 minutes. So the simple things I look for is night pain. Can they walk for at least 10 minutes, 10 to 15 minutes? Can they do at least 20 to 30 seconds of a single leg stand? Just even holding a chair, can they do that? Can they do at least 10 bridges without much of pain? If they can do that, then I think they're ready. If they can't even do those basic ADLs, then you should be focusing on a non-shockwave treatment option rather than just giving them another painful stimulus.
Okay, fine. And then what do you do in terms of impulses or shocks per session? Have you come round to an idea on that?
Yeah, so impulses, as we know, you hit the ceiling point after 2,500 to 3,000. So the maximum impulses I would give them is, I never ever exceed 2,500. I might give them a 500 as a warm-up dose, especially on the first session with a high frequency. So I might give them like a 13 to 15 hertz. Because that's more like desensitizing the area so that they can take the main dosage. Mm-hmm. So it could be so the main treatment might be 2 to 2.5K, and then the warm up dose might be 500. Now if I am working on a lot of them will have some myofascial pain and bit of tightness there, so I might give another 1,000 working around the myofascial area. Working especially the chronic cases. So in total, you're looking around 4,000, the whole thing. And so I look at it as a complete package, really, rather than just focusing on the insertion of the tendon, because it's one unit, isn't it?
Yeah. And if we can just go, because I just speaking to you before, I know that you bought the focused device now. Have you started building that into your repertoire of GTPS and high hamstring and so forth? And how are you getting on with it so far?
Yeah, I think the focus is fantastic. I'm lucky to get access through the Life Plus clinic. So what I find is we got good evidence that it's superior to radial in plantar fasciitis. We've seen few trials, but we still not seen that from a tendon point of view, because most outcomes they use for tendon is like 3 months and 6 months, so it sort of evens out. But having said that, I think it still has a very good role. One, I think, is especially the beauty of focus is you could use it in people who is a little bit more painful than in a radial. So somebody who has a bit of high pain levels, bit irritable, they seem to tolerate focus better than radial. So that is a good option. And also another advantage is the depth. We know that focus, you can go all the way to 8 to 12 centimeters, especially with somebody with a large BMI. That's a bit more useful. So the thing, when I been to the stores headquarters like in Zurich and other places, I think the way forward is a combination. You hit the focus on the most painful, effective area, and then the surrounding area you work on the radial. So from anecdotally, the combination seems to do well, but we don't have any hard data to prove that. But I'm sure the evidence will come in time. So I think it's not. I don't think it's like, is it radial or focus? I think they sort of complement each other. So it's great to have the access to both the devices if possible.
Sure. Okay. Great. I think the only thing I'm going to leave you with is that I've been to one of your teaching courses as well, and it's one thing that I try and put across as much as possible on this podcast is that I think the key message when we start talking about tendons amongst ourselves is that we're concerned. I think that it's becoming a one-stop shop for fixing tendons without any of the other stuff. But the people that know a lot more about tendons than I do, including yourself, will definitely say it's an adjunct to a good supportive treatment of that patient, and that's what I just wanted to get across today, because I know you're a great believer in that.
Yeah. So I think, for example, like it's all good clinicians give multimodal treatment. That's a problem with research, because they look at one treatment in isolation. That's how good research is. But in reality, we're going to give multiple things. So if you get somebody with a GTPS, suppose like a middle-aged runner, male or female, so you're going to look at first with the load management, are they overtraining? Look at that aspect, psychology aspect, sleep, recovery, all that stuff, and then you're going to start them on a simple graded loading program. Not everybody needs to start with isometric. You need to find a suitable starting point, and then you might look into any associated deficits. For example, one of the things I see missed in GTPS is we know from the research a lot of them have weakness in their same side quads and calf. So a lot of them have associated deficits. So it's just not the hip abductors which are weak. A lot of them have quad weakness, they have calf weakness on the same side. So we're going to address the whole kinetic chain,
Mm-hmm.
And then we might look into the gait analysis, whether they're having any issues with that, and return them back to plyometrics. And sometimes I might even get help from my podiatric colleagues when I feel there's other things associated. So it's sort of a collaborative, multimodal approach rather than saying Shockwave. And the Shockwave really gets you into that sort of facilitates. I think it's a great facilitator in rehab. That's how I explain to my patient. It facilitates you into engage in rehabilitation by reducing in pain, but it really doesn't change anything intrinsically. What changes is what you put in. If you don't make that changes from your lifestyle and with your exercises, your tendons will not be different. So a pure passive approach is not the way forward for a multifaceted condition like tendinopathy.
I think there would be no better time to finish this podcast, because that was brilliantly put, Ben. I am going to wrap this up and say thank you very much. And I'm pretty sure that if we continue doing podcasts, we're going to get you back on to discuss something else later on. But thanks for your time today, Ben. Thanks a lot.
Yeah. Thanks, James, for inviting me.